Hello everyone. Have a nice day, inshallah. So this is about disorders of potassium hemostasis. Potassium, as you all know, is a major intracellular cation. Steep concentration gradient for potassium across the cell membrane of excitable cells plays an important part in generating the resting membrane potential, allowing the propagation of the action potential that is crucial to the normal function of the nerve, muscle, as well as the cardiac tissues. So hyperkalemia, more potassium intake, more plasma potassium lead to negative feedback in the adrenal cortex, that is in the zona glomerulosa. There will be increase in aldosterone affecting the kidney for more hyperkalemic excretion. This is the feedback control of plasma potassium concentration. This is to be kept in mind as a physiology, normal physiology for potassium. Hypokalemia is common in electrolyte disturbance and is defined as existing when the potassium falls below 3.5 millimole of liter per liter. This is to be memorized, 3.5 millimole per liter. These are the causes of hypokalemia, is to be recognized in the memory all the time. Reduce intake, redistribution into cells, increase urinary excretion, increase gastrointestinal loss in cases of loss of gastric and associated with metabolic alkalosis. Clinical features: generally asymptomatic, but more profound reduction in plasma. The more we lose potassium, often lead to muscular weakness, associated tiredness. There will be ventricular ectopic speed, or more serious arrhythmia can occur. Functional bowel obstruction may occur due to paralytic ileus. Long-standing hypokalemia may cause renal tubular damage, that is hypokalemic nephropathy, and can interfere with tubular response to vasopressin. This is what will lead to what we call acquired nephrogenic diabetes insipidus, resulting in polyuria and polydipsia. And this is the ECG pattern in hypokalemia. This is the ECG pattern usually seen in hypokalemia. How would we manage hypokalemia? By looking after the underlying cause, correcting this if ever possible. Potassium replacement, slow release potassium chloride, intravenous potassium chloride may be necessary in dangerous and critical cases. In the less common situation, hypokalemia occurs in presence of systemic acidosis, alkaline salt or potassium, such as potassium bicarbonate. In magnesium depletion, if it is present, replacement of magnesium may be required. Potassium-sparing diuretics, such as amyloid, can assist in management. Hyperkalemia is common in electrolyte, which is defined as existing when serum potassium is more than 5 millimole. In hypokalemia, the figure is less than 3.5 millimole. In hyperkalemia, it is more than 5 millimole per liter. And these are the causes of hyperkalemia. We should recognize them. We should avoid them. We should look after them. We should think of them. Clinical features include mild to moderate hyperkalemia, less than 6.5 millimole per liter, is usually asymptomatic. In severe hyperkalemia, it can present with progressive muscular weakness, but sometimes there are no symptoms until cardiac arrest, that is very dangerous, can occur. It is lethal. So this is what happened by doing ECG. In your emergency unit, all the time, think of hyperkalemia by doing ECG. Why? This is lethal. This is critical. It endangers patient life. So peaking of T cell. So there is peaking of the T cell on the ECG, widening of the QRS complex. That it's dangerous cardiac will lead to dangerous cardiac dysrhythmia. These characteristic ECG findings are not always present even in severe hyperkalemia, but always put it in mind. This is very important. Management, treat hyperkalemia depends on its severity. So stabilize cell membrane, IV calcium, this should be memorized on heart. IV calcium gluconate, 10 ml of 10% solution slowly, shift potassium into the cell, inhale beta-2 adrenoceptor agonist, IV glucose, 50 ml of 50% solution, and insulin and IV sodium bicarbonate. How can we remove potassium from the body? IV furosemide, potent diuretic and normal saline, ion exchange resin, and orally or rectally, and dialysis to rid the body from extra potassium that can endanger a patient life. Hypomagnesemia is defined as existing when plasma magnesium concentration are below the reference range. And what is the reference range? This is the reference range. It is below 0.75 to 1 millimole per liter. And inadequate intake of potassium is a cause of magnesium, is a cause of hypomagnesemia, and excessive losses, gastrointestinal or urinary or miscellaneous, such as acute pancreatitis and others. Always look for hypomagnesemia. Clinical features: in mild degree hypomagnesemia, it may be asymptomatic. More severe hypomagnesemia may be associated with symptoms of hypocalcemia, such as tyranny, cardiac dysrhythmia, and central nervous excitation, and patient may have seizure and hypertension. Hypomagnesemia and magnesium depletion are also associated through uncertain mechanisms with hyponatremia and hypokalemia. So look for, when you think of hyponatremia, there is low sodium, and hypokalemia, there is low potassium, you think of hypomagnesemia. I see what the brain says. If you don't think of it, you will miss it. This will contribute to some of the clinical manifestations your patient might have. And this is what we call tertiary pointes bradycardia with long acuity interval. If you look, it is a bradycardia with long acuity interval, and followed by polymorphic ventricular tachycardia that is triggered an R on T ectopic. Management: manage the underlying cause. Look for the underlying cause. When symptoms are present, treatment of choice is intravenous magnesium. Intravenous access is not feasible. Magnesium, if it is not feasible, think of magnesium sulfate can be given intramuscularly. This is an emergency. Oral magnesium salts have limited effectiveness due to poor absorption and may cause diarrhea. Magnesium and diarrhea. Think of oral magnesium as a cause of diarrhea. And hypomagnesemia is caused by diuretic treatment. Adjunctive use of potassium sparing agent can also help by reducing magnesium loss in the urine. Hypermagnesemia, there are predisposing causes for this in acute kidney injury, in chronic kidney disease, and in adrenal insufficiency. Increase intake of magnesium, use of magnesium containing medications and antacids, laxatives. Elderly used to have laxative and enemas. Thinks of hypermagnesemia. Clinical features will include bradycardia, hypotension, reduced consciousness, and respiratory depression. Put hypermagnesemia all the time with patients who are consuming a lot of antacids or consuming a lot of laxative and enemas. We manage them by ceasing all magnesium containing medications, improving renal function if possible, promoting urinary magnesium excretion using a loop diuretic with intravenous hydration. Calcium gluconate may be given intravenously to ameliorate cardiac effects. Dialysis may be necessary in patients with poor renal function. Dialysis will rescue life. Hypophosphatemia is defined as existing when serum phosphate values fall below 0.8 millimole per liter. That is 2.4 milligram. Clinical features include blood and paired function and survival of cell lineage. Skeletal muscle, there will be weakness. Cardiac muscle, there will be congestive heart failure. Smooth muscle, there will be ileus. Central nervous system, patient is stuporous, might have seizures and coma even. Bone osteomalacia and severe prolonged hypophosphatemia. Management of hypophosphatemia due to decreased dietary intake or excessive losses involves administering oral phosphate supplements, high protein, high dietary supplements, and rich in naturally occurring phosphate. Intravenous treatment with sodium or potassium phosphate will risk the body. In hyperphosphatemia, most common cause by acute kidney injury or chronic kidney disease. Clinical features relate to hypocalcemia and metastatic calcification, particularly in chronic kidney disease with tertiary hyperparathyroidism. Hyperphosphatemia in patients with kidney disease should be managed with dietary phosphate restriction, use of oral phosphate binders. Hyperphosphatemia associated with the tumor lysis syndrome and catabolic states can be treated with intravenous normal saline, which is given to promote phosphate excretion. What is the tumor lysis syndrome? When we give cytotoxic to patients, the tumor cells will have lysis. There will be hyperkalemia, hyperuricemia, hyperphosphatemia. So they should be managed with these intravenous normal saline that should be given previously to promote phosphate excretion. And this is the building of Baghdad College of Medicine in Baghdad, University of Baghdad. That was the first College of Medicine launched in the Middle East after the Cairo, of course, College of Medicine. It was in 1927. Have a nice day. Thank you for your attention.